Well, good evening, everyone, and welcome to the IMF teleconference, Myeloma Updates 2016, Post-ASCO, American Society of Clinical Oncology, EHA, European Hematology Association, and IMWG, International Myeloma Working Group. This is our third teleconference this year, and I assure you it's going to be very informative. Our speaker tonight is Dr. Brian Durie, Chairman of the Board of the IMF, and he'll be updating you on what happened at these three major meetings that took place last month. Needless to say, the month of June was incredibly busy. The three meetings were ASCO, American Society of Oncology, which takes place in Chicago, then EHA, and then finally the International Myeloma Working Group meeting, which along with EHA was held in Copenhagen, Denmark. So needless to say, many people were rushing from the U.S. to Denmark to make sure that they were there for all these important meetings. So Dr. Durie has quite a job ahead of him to update you on all the high points of these meetings. But I know he's ready and well prepared to give you a very thorough overview of all the important papers and data that was presented. Before I turn it over to Dr. Durie, I'd like to take a moment to thank our sponsors of tonight's teleconference. Without them, this would not be possible. So I'd like to thank Amgen, Bristol Myers Squibb, Celgene, Janssen, and Takeda Oncology. It's really wonderful that they support this program, and it's greatly appreciated. One last thing, as a reminder, you'll find the link to tonight's slides by going to our website and under New and Noteworthy, which is on the right-hand side of the first page. It's the first bullet down. That's the link to the slides. So just click on that and you'll be all set. So now sit back and relax, and Dr. Durie, it's all yours.
Well, thank you so much, Susie, for that introduction. And I appreciate this opportunity to review these three important meetings, which are basically a mid-year update of the status of what's going on in the myeloma field. I want to reverse the order of the meetings, actually, and start with the International Myeloma Working Group Summit, because this was a particularly active summit this year and some very important topics were discussed. And so I'm going to start by talking about the IMWG Summit, and then I will talk about the presentations at ASCO, and then finish up with comments about the EHA meeting. And so this was the 7th International Myeloma Working Group Summit, and this is a meeting where about half of the total membership of the working group get together for focused discussions on different topics. And so this has become a very popular and a very active meeting, and this year was certainly no exception. And so if we go to what is listed as slide number 3, which says, let's start with the IMWG Summit, because it really was a big success this year. And I've listed for you 8 topics that I'm going to touch on at various depths. I don't have time to go in full depth about each of those. The first one I will spend some time on, and I'm sure iSTOP myeloma is certainly something that we all want to do, and so I'm sure you'll be glad to hear some details about how we propose to stop myeloma. I will update on status of MRD testing and results, touch a little bit on the role of imaging, MRI, PET-CT scanning, give an update on immune therapies, which was a hot topic discussed by Dr. McHale at the summit. Where are we in looking into trying to cure myeloma? One interesting discussion, which has not happened at the summit before, is where are we with FISH testing? Many of you are familiar with FISH testing, and the question posed by Gareth Morgan at the summit was, maybe we should just be doing sequencing instead of the FISH testing, where we might be able to look in a comprehensive way at all of the mutations in the myeloma cells. So I'll comment on that. The role of transplant, especially in a frontline setting, and a big topic in this middle part of the year is the cost of therapies, and how do we stratify or rank therapies taking into consideration the costs. So let's start with iSTOP MM, slide number 4. If you go to that screen, you'll see I stands for Iceland. Iceland, and you'll see a picture of Iceland right there in purple. Iceland screens, treats, or prevents multiple myeloma. And how in the world are we going to do that? Well, the first thing is to be aware that it will involve the whole of Iceland. And so this is a very exciting project. This is a project which will encompass all of the people who live in Iceland, and there are a total of 35 laboratories in Iceland where patients might go to have blood samples taken. And the idea is that wherever they live, they would go to the closest laboratory to get the blood testing done. And so if we go to the next slide, we'll see how did such a tiny island of Iceland get to be involved? Well, you may have noticed in Euro 2016, Iceland did remarkably well in the soccer tournament in Europe, and in fact, there was huge excitement because they beat England. Unfortunately, they did subsequently lose to France, but they beat England, and this was a huge achievement for this country. And there was a joke going around, if you look at the population of Iceland, which was like a tenth of the population of England, and you calculate what the people in Iceland are doing and whether they might be able to play soccer or not, that you're actually left with about 23 people who would be able to play soccer. So the thing is that if a country puts effort into it, it is amazing what can be accomplished, and this is an amazing accomplishment for this country to put this effort together and to collaborate with the International Myeloma Foundation. And so this is a new Black Swan research project that we have initiated in collaboration with the principal investigator, Dr. Sigurdur Christensen at the University of Iceland. And so one more piece of information, which is on slide number 6, which says the importance of the deCODE project. And some of you may have heard about this. Because of the limited number of people who live in Iceland, it has been possible to do whole gene sequencing on the population, whole genome sequencing. And so, as you can see highlighted in green on slide number 6, 2,600 Icelanders were fully sequenced, which means that the complete DNA sequencing was carried out for them. Now, the second aspect is that the population of Iceland represents closely linked families, and so by looking at the family trees and identifying high-risk families, families where diseases have occurred, it was possible to come up with some gene variants which seem to be linked with different diseases. And so by looking at the different disease markers, which are called SNPs, single nucleotide polymorphisms, it was possible to get DNA samples from 120,000 people in Iceland and chip type them for these gene sequences that are linked to disease. And so a very important aspect of starting this study in Iceland is that we understand a lot about the DNA and the genes of the people of Iceland. And so if we go to the next slide, which is slide number 7, this gives you the full summary of what we're going to do. iSTOP myeloma. Iceland screens, treats, or prevents multiple myeloma. So what does that mean? Well, if you look at the bottom, there are 140,000 adults who are over the age of 40. And so what that means, if you take a blood sample from them, we can determine if they have a monoclonal gammopathy, if they might have smoldering myeloma, and in particular, we can see if they might have high-risk smoldering multiple myeloma, HRSMM, which is the early stage of myeloma, which you may know, and I'm going to talk about in a minute, is the category of patients where we're looking to implement cure trials. And so if we have an intervention with treatment early, we have the possibility to actually prevent the development of full myeloma and to cure patients from getting myeloma. And so this is a very, very key aspect of the project. In addition, if you follow the other two lines, you can see that patients who might have a monoclonal protein present in the blood at a low level can be monitored, and then they can be tracked to see which ones go on to get myeloma. Because we know so much about the Icelanders, we know their DNA, we know about their families, we also know a lot about their jobs, their occupations, whether they might be exposed to toxins and all kinds of things. We know a lot about these patients, so we can understand and categorize patients who are likely to get myeloma. And you can see, I think you can probably see that for the whole country, we can end up knowing a lot about the Icelanders, who's going to get myeloma, and maybe be in a position to prevent or to treat all of the myeloma for a whole country. And I can assure you this is tremendously exciting, and it's amazingly exciting for Dr. Sigurdur Christensen and his team, who are so excited and motivated to move forward with this project. The binding site are the ones who are co-sponsoring this project with us, because they are going to run the protein testing and the light chain analysis to identify MGUS, Smouldering, and active myeloma. So we're really, really excited to start this project, which will be kicking off later in the summer into the fall period. So this was presented as actually the first presentation at the IMWG Summit, and I have to say there was tremendous excitement in the room about that. But if we go to slide number 8, the second topic we talked about was where are we with minimal residual disease testing, MRD. And as many of you are aware, this is about looking at the bone marrow to see if there's any low level of myeloma in the bone marrow. And we have a lot of methods to do that, using a flow method, using PCR methods, or gene sequencing methods. And you can also look using PET-CT scanning to see if there's a spot of myeloma anywhere. What I'm going to focus on is flow cytometry, which is a method that we have worked on closely with the Spanish team and a European flow team to develop a very specific and sensitive method to see if any myeloma is left in the bone marrow. And so if you go to the next slide, you can see that a first step in evaluating MRD was to come up with some criteria as to what minimal residual disease testing would mean for a multiple myeloma patient. And so in this table that you have on slide number 9 is the IMWG criteria for MRD in myeloma, and we have just found out, we just found out today that this paper will be published in Lancet Oncology next Tuesday. And Dr. Shaji Kumar is the senior author from the IMWG group. And in the red box at the top, I want to draw your attention to what is a very key definition which has been agreed to by all of the members of the IMWG, and that is sustained MRD negative. And what this means is that if you do the MRD testing in the bone marrow and it's negative by sequencing or flow, and the PET-CT scan is also negative, and this is confirmed 1 year later, this is sustained MRD. Now, why is that important? Well, what we think is that if this turns out to be the case, that a patient is negative by all these methods, that this will be an indicator of the possibility of being cured. And we know for sure that if that MRD is sustained for 3 years or for 5 years, the chances that a patient could well be cured increases dramatically and becomes more and more secure. But what is very important is to have this definition in the background that we can use within our clinical trials and say, look, we have established that this treatment can achieve sustained MRD negative. And so just to give you a little bit of detail about the flow test, which has turned out to be unusually good, this new flow test is called Next Generation Flow. And so this is a test where you pass the bone marrow cells through this flow cytometer, and you evaluate it with 3 different aspects being considered. On the left, you'll see 3 puzzle pieces. This is on slide number 10. You need to have the correct antibodies to identify the myeloma, and we have an 8-antibody cocktail. We need to process the marrow with this bulk lysis, which is a way of preparing the myeloma cells for identification. And then we need to have a novel or a new computer software program to analyze the results. And those three things have all been accomplished within the past couple of years to have a highly sensitive and a very reliable test. And so if you get to the next slide, what about the automated analysis? Well, what the automated analysis means is that the results are passed through a computer. So on the left of slide number 11, you can see there are lots of different clusters. If you look to the right, you'll see that the clusters start to fall into particular colors where the cells have been classified into different groups. And this is what we need to get an answer from the bone marrow analysis. And so if you go to the next slide, it gives you an idea of how this works. And so if you look at the left here, you can see that you have these clusters inside a box. And then if you look at the 6 panels on the right, you can see that these are displayed in different ways. And so if we take the big kind of dark red box, almost like a maroon color, it's a big red cluster, you see it's at the bottom of the box. And then you'll also see that it's in the middle panel on the top of the 6 boxes. You'll see there's a maroon cluster there, which is on the bottom left. And it's at the bottom where it has a low CD45 and a low SSC, which is light scattering. And these cells are nucleated red cells. So these are cells which are capable of making red cells. So why is that important? It's very important because it means that the bone marrow is actually bone marrow. It contains cells capable of making red cells. So this tells you, it gives you what's called at the top immediate and simultaneous quality control. So you know that this is bone marrow, and so then you know that whatever the percentage of plasma cells is reliable because it's within the confines of a known bone marrow sample. And you can see at the bottom that if you do this, we find out that 7.5% of samples are not good. And it's incredibly important to know which samples those are. If you go to the next slide, which is slide number 13, you can see, well, how sensitive is this method? And I would say, and I think everyone has been truly amazed with 2 things about the next generation flow. The first thing is that compared to the sequencing method is only possible in some of the samples. In this case, when we tested 87%, the test was possible. In some cases, it just doesn't work. But in the middle channels, you can see there that next generation flow was positive in 6 out of 27 samples, if you look to the left, where the next generation sequencing was negative. And so what that means is that the next generation flow was more sensitive than the sequencing. And this really had not been predicted. 6 out of 27 is 22%. So this is a significant percentage. Now, the interesting thing is, if the flow test is positive, what does that mean for the patient? And what we found out is that already, of those 6 patients, a couple of them have already relapsed, so that we know that that has meaning. The interesting opposite thing is, if you look in the red box, there was one patient that was negative with flow but was positive with sequencing, but that patient has been doing just fine, which means that it could actually be a false positive with the sequencing method. So, if we go to the next slide, this is incredibly important because this means that we are definitely on the way to documenting the likelihood of cure, and that is that if you look at what happens to patients who are next generation flow negative, this is the blue curves on both of these charts compared to different red curves. But if you look at the blue curves, you'll see in both of those that the curve is flat, and what that means is that the progression-free survival is close to 100%, which means that the patients are staying in remission. out to, and you can see it's headed out towards between 2 and 3 years. So this is amazing. One very interesting and important point is that you'll notice that there was a slight drop in the blue curves right at the beginning. And so we tested all the samples, but we found out when we tested the 2 samples that caused that drop, those were actually bad samples. And so those samples were actually positive. And so if you look at the good samples, the curve turns out to be completely flat, out to headed towards 3 years. So very, very promising. So what has the IMF been doing to try to make this test available? And I know it has been incredibly frustrating. And so if you go to slide 15, you can see where we are with this. And so we have been working with sites across the U.S., and we have 2 sites, Mayo and Roswell Park, which are reference labs, so that if anybody wants to get a test done, samples can be sent there. But you can see that we have several centers in New York, Chicago, Michigan, UCSF, Seattle, City of Hope. We're blanketing the country in terms of places where patients can get the testing done. And if you go to the next slide, you can see that we actually are doing that globally. We have 40 researchers in 16 different countries, in Europe, in Asia, also in Iceland. You'll see the little swan there swimming on Iceland, but also in Australia. So we're very, very pleased about that. And we have a meeting coming up in the fall where we're going to review all of the methodology in Salamanca. All right, so let me move on and touch on some of the other topics at the summit. Immune therapies, slide number 17, very beautifully discussed by Dr. McHale. There was great interest in some of the newer technologies. Where are we going to go with the CAR T cells? This is an engineered T cell which is given back to the patient and can attack the myeloma. Many new types of those are being developed. Even natural killer cells are being designed to be used in that way, and I'll touch on later some information about checkpoint inhibitors. So a lot of interest in where are we headed with the immune therapies. Slide number 18, just to put this in perspective, these immune therapies were part of the 4 drugs that were approved right at the end of 2015, the daratumumab, the elotuzumab immune therapies. And so if you go to slide number 19, what was a focus for discussion at the summit was the reality, even for experts, is what is the optimal choice? We have all these therapies now. How do we decide between them? And this was the focus of a big controversial discussion that many of you are aware of, which was the ICER discussion, trying to prioritize what is the impact of these novel therapies, what is the cost of these novel therapies, and which ones should be preferred. And what was, I would say, unanimous at the IMWG Summit is that the myeloma experts do need to step in and come up with what we're calling stratified guidelines. We try to indicate, keeping in mind the access and the cost, which therapies do we recommend? Frontline, particularly for early relapse where the new therapies have been introduced, and come up with some guidelines, which you can be looking for in the near future. If we go to slide 20, there was a lot of discussion about, is cure a dream worth trying to make reality? And Professor Jesus San Miguel from Spain discussed this in a very, very interesting way. He pointed out that using allotransplant, we have seen patients that we think may be cured, and this was some years ago, but allotransplant is quite toxic and is only available for young patients who might have to have a donor, a matched donor. And so this is really not a practical approach for very many patients, and it still is quite toxic. Autologous stem cell transplant, we have seen 5 to 10% of patients who can remain in long CR, and we've also seen novel drugs increasing the survival, especially when used in the upfront setting. And so he proposed a definition of what we would be trying to achieve. We would like to see the fraction of patients who have CCR, continuous CR at 10 years, we'd like to see that increase at least to 30-50% with proposals that we can make right now. And so what are those proposals that he presented? Well, for myeloma, his proposal was to use the combination of carfilzomib and Dara along with Revlimid and Dex up front. Consider some kind of a transplant, consolidation, and maintenance. If you go to slide number 22, what is even more exciting is that if you start earlier and treat high-risk smoldering myeloma using, for example, the CESAR trial, which some of you have heard about before, which is carfilzomib, Revlimid, and Dex, KRD for 6 cycles, a transplant, consolidation, and then maintenance with Revlimid and Dex, Lenalidomide and Dex, we feel like this could be a curative regimen and could meet the criteria that Jesus San Miguel indicated of being 30 to 50% MRD negative at 5 years. Okay, so that MRD negative does include imaging, and so Professor Zamagne from Bologna did present data on that, and so if you are both imaging and MRD negative, she showed that there's right around a 90% chance that you will indeed stay negative at 3 years, and this is using just VRD and transplant. So very, very interesting to see that documentation just using less aggressive treatment in patients who do already have active myeloma. So let me move now to ASCO and just give you what was going on in Chicago at ASCO, and just to say a few things broadly. This is a meeting that runs from Friday to Tuesday. It's a much longer and less intense meeting versus ASH. It's much more of an educational meeting for hemoncs who do not deal so much with myeloma. So it's a rather different meeting versus ASH, where you have the myeloma experts there, and many of the heme doctors are very much focused on myeloma. And so there are a lot more educational meet the professor and discussion sessions that are spread out all the way through those days, which is a much longer meeting. The main oral session, which was on Friday, had 8 abstracts. So it's not like ASH where you have multiple competing sessions. There was a plenary session which included the CASTOR study that I will focus on, and then there were 3 novel therapy abstracts that were on the Tuesday session. So if you go to slide 25, you'll see that just to give you an idea of what were the education sessions about, they were about defining myeloma, rare subtypes of myeloma, a lot of discussion about the highlights from the oral presentation, so really kind of explaining the significance of the abstracts to the participants at the meeting, including not just the oral sessions, but also the poster sessions. So if we go to what was really the main or the most important presentation at the ASCO meeting, and that is on slide number 26. This is the CASTOR study, and this was a late-breaking abstract, and that was one that was accepted because it was an important result. And this is a large study that compared DVD, which in this case means daratumumab, which is the anti-CD38 monoclonal antibody, combined with Velcade-Dex versus Velcade-Dex alone in the relapse setting. And so a lot of interest to see how much better patients would do if they got the daratumumab plus the Velcade-Dex versus the Velcade-Dex alone. And many of you will see the similarities of many of the other relapse studies that we've seen recently, elotuzumab and ixazomib and the like, tested in a very similar way. So if we go to the next slide, the CASTOR study results. This is on slide 27. You see that I put a picture of CASTOR right there for you. CASTOR is one of the twins. There's twins, CASTOR and Pollux, and the designers of the study were kind of playing a joke because they had twin studies, daratumumab with Velcade-Dex and daratumumab with Revlimid and Dex, which is the Pollux study, the other twin. And I'll tell you about that in a minute. But the first twin, the CASTOR study, you can see immediately what are the results. The results were definitely better with the daratumumab combination. The length of the remission, the PFS, not reached versus 7.2 months. The 1 year in remission, 61% versus 27%, a big difference. Achieving PR, a 20% difference, 83% versus 63%. And what was quite interesting in the relapse setting, they did test if patients achieved MRD negative, and that was 14%, very significant. I would draw your attention to the bottom right-hand box, which is something that you may not have heard about before. It's something called the hazard ratio, which tells you a little bit about the importance of the p-value, and in this case, the lower the number, the more important it is. In this case, the hazard ratio was 0.39. Now, if you look at, well, what was the hazard ratio for carfilzomib Revdex versus Revdex, that was 0.53. If you look at, well, what was it for elotuzumab Revdex versus Revdex, it was 0.72. Now, you should not really compare across trials, but this is what a lot of investigators have been doing, to say that this result is highly significant compared to what we've seen with these other combinations. Okay, slide 28. So what were some of the other oral sessions? And you see I've listed them there. Upfront transplant, Revlimid maintenance, ixazomib frontline, genetics, new diagnostic criteria, the use of SAR, which is the other anti-CD38 antibody, a new drug, Pledepsin I'll talk about, CAR-POMDEX, and ixazomib POMDEX. So I will only have time to go into a few of those to give you an idea of what the results are. So if we look at the upfront transplant on slide 29, you'll notice that a very large number of studies and patients in these studies, 1,503 patients, half of them, or a little bit less than half of them, got Velcade, methylprednisone. The other patients got Cytoxan, Velcade, and Dex. So similar combination, but more intense, and they also got autologous stem cell transplant. And as you might expect, the upfront CyBorD transplant patients did better. They had an 84% versus 74%, and the remissions were better with upfront transplant. So certainly supporting the role of upfront transplant. The next one was the value of lenalidomide, which is Revlimid maintenance, post-autologous stem cell transplant. And this was what's called a meta-analysis or a compilation of results from 3 randomized trials representing 1,209 patients. Bottom line, pretty straightforward, and I think I was impressed that people really felt that this was important. It showed that the median overall survival of 86 months versus not reached was highly significant. So bringing those 3 studies together, there was a survival value of Revlimid maintenance. And I sensed that people were finally saying, well, maybe this is a sufficient evidence that Revlimid maintenance does need to be considered. It was also important to note that there was benefit for patients who had less than a partial remission, as well as those who had deeper responses. Not just limited to patients who had lesser responses with the therapy previously. So an interesting presentation from the team at Memorial Sloan Kettering in New York was genetic plasma cell signatures in high-risk smoldering myeloma versus multiple myeloma. This is on slide number 31. So basically, this is a question about what are the genetic differences between smoldering and active myeloma. And this was very interesting. So if we go to slide number 32, you can see, well, what is the difference? And the difference was in the presence of what are called significantly recurring multiple myeloma gene mutations. And so those are important mutations involving, for example, RAS genes, which are oncogenes. And you can see that there are lots of green squares in the patients with newly diagnosed myeloma, and there are very few green boxes over on the right with smoldering myeloma. And so what the MSK team, led by Dr. Landgren, were able to show was that these important mutations occurred in active myeloma, but were much less likely in smoldering myeloma. And so this is an argument to treat early before these mutations occur. So very, very important point. So moving quickly to the slide number 33, this tells you what were the novel combinations presented. Pembro, which is a checkpoint inhibitor combined with Revdex, giving good preliminary results, 76% partial remissions. Venetoclax, which is a BCL2 inhibitor, also good results, 51%, combined with Velcade-Dex. And then a completely new agent, anti-EF1A2, that would take a long time to explain, but good preliminary results in that combination. So very exciting to see new drugs moving forward. What was quite interesting, and I'm not going to go into a lot of detail, slide 34, the focus on value and costs. And there were a whole flood of abstracts, predominantly as posters, looking at value and costs. The interesting thing was that depending on how you looked at it, you can show that one thing is more expensive than another. One thing was routine management was more costly than the cost of the drugs. Another study showed that triple therapy is actually a good idea because even although it's more expensive, it reduces other costs. VRD is more costly, but it's better than CyBorD for high risk. But then, once it got into comparing pomalidomide with carfilzomib and other therapies, there were mixed results. Depending on how you looked at it, you can show that one was more or less costly than the other. And as we all know, treating adverse events is expensive. I think the only takeaway I have is costs are definitely high. So the final thing I want to touch on, possibly the most exciting mid-year trial results, is the Pollux study. And so if you look at the next slide, slide number 35, I've got the Pollux twin up on the right there. Just for those of you interested in mythology, Pollux was the immortal one of the twins. Unfortunately, CASTOR was not immortal. And so Pollux was in much better shape. And it turns out that the Pollux study has even more dramatic results versus the CASTOR study. And so you'll see large numbers of patients here, daratumumab Revdex versus Revdex, over 200 patients in each arm, and moving forward, staying on treatment. And so if you go to the next slide, what were the results of the Pollux trial? Well, people were incredibly excited, not about the fact that just the Dara was better, but that it was better in such a dramatic fashion. And this shows you the length of the remission, the progression-free survival with the daratumumab Revdex. And so what you can see here is, and these are in early relapse patients, 80% of the patients getting daratumumab Revdex were still in remission at out close to 2 years. And so the hazard ratio for this was even lower at 0.35, so a very, very significant benefit. And what caught people's attention is that with daratumumab Revdex, in the relapse setting, 30% of the patients ended up being MRD negative. So really a dramatic impact from this combination. Really, really exciting. So I can tell you that many people so excited about that. So what can we say are some of the key issues for 2016 heading into 2017? Well, I think that we really need trials. And we need trials of the different drugs, and we need trials of different concepts. And the participants of the IMWG Summit went home with lots of to-do projects to come up with new trials. How do we prevent progression of smoldering myeloma? How do we come up with a combination that could be limited and achieve the results without expensive ongoing continuous therapy? How do we determine what is the best triplet? How do we routinely identify the molecular subtypes? And how is it that minimal residual disease is really, really going to improve our outcomes. And so my final thoughts as we head into the question time here is we definitely need to continue to find new therapies, but the major to-do for myeloma doctors and also on the minds of patients is we need to learn how best to use the therapies that we have and prioritize these therapies to get the best results, the fewest side effects, and in a manageable, cost-effective way. And so this is a major to-do mid-year heading into the latter part of the year. And so with those details and thoughts, I'll stop and be ready for questions.
And you do have a question from the line of Candace.
All right, Candace.
Yes, I have a question about oprozumib. It's the oral proteasome inhibitor being developed by Onyx. What is the status of that?
That is still in trials. There were not any new presentations about that at ASCO or EHA. There was a presentation at ASH where it was reformulated. There was some toxicity with the original formulation. So it's a by-mouth proteasome inhibitor, similar to ixazomib, but there were some toxicities that required it to be reformulated, and so the trials with the new formulation are going forward, and I suspect we'll get some new results of that new formulation upcoming at ASH. So it's just running a little bit behind on the testing.
Oh, okay. Thank you very much.
No problem.
And your next question comes from the line of John.
Yes, thank you, Dr. Durie. Was any new information discussed regarding the use of bisphosphonate? Any known changes or toxicities or any changes in the way that it's been administered to myeloma patients?
I don't believe there were any, there were certainly no major presentations on that. There have been a number of presentations, there was some at ASH, looking at, comparing Iridia, which is pamidronate, versus Zometa, which is zoledronic acid, looking at the dosage. So it's not so clear. There was a study from Scandinavia, for example, that looked at using 30 milligrams of Iridia versus 90 milligrams, actually showing equal results. So that there's a possibility that lower doses could be effective in myeloma. I think there's still ongoing discussion about how long should you stay on, for example, Zometa. I think the current recommendation still holds that after 2 years you should maybe think to cut back or even stop over time. But really nothing major. There were some new guidelines that came out related to osteonecrosis of the jaw, how to identify and proactively treat that. That could be something useful for those who might be concerned about that. That was actually a nice review that came out, but it was not presented at our meetings.
Okay, thank you.
And your next question comes from the line of Kathleen.
Hi, Dr. Durie. I was
Hi.
just wondering if there were any studies presented or discussions about the optimal dosage for Revlimid maintenance.
Yes, there was some discussion about that related to this meta-analysis, and I guess the main thing is that in the maintenance, the 10 milligram dose is the normal dose. There was also some discussion about the pros and cons of reducing the dose versus stopping, with the idea that if you reduce it from 10 milligrams to 5 milligrams, since we do see survival benefit if you can stay on the maintenance, it's worth trying to adjust the dose to stay on it versus stopping it. Now, Separately, I would say in the study from SWOG, which actually I chaired, which was VRD versus RD, the starting dose and the maintenance there was 25 milligrams. But in that study, the same was true. There were like 30-40% dose reductions, and 10 milligrams is really the dose that can be tolerated, and even there with dose reductions.
Okay, thank you.
Yeah.
Yes.
And your next question comes from the line of Judy.
I have
Hi,
a
Judy.
question about. Hi, I have a question about the potential link between Revlimid and metastatic colon cancer. I've been reading online that they do find a link, and it's something that did happen to my husband. He was on Revlimid for 4 years, and then was diagnosed with stage 4 colon cancer. And I was just wondering if there really is a link.
Well, this is definitely an ongoing concern, I would say, and this absolutely always comes up in the discussion, and quite frankly, is something that has to be discussed with every patient who is starting on Revlimid maintenance. That the percentages are relatively low. Obviously, for a patient who gets colon cancer, it's 100%. In the bigger picture, the increase is from, maybe 2 to 3% versus twice that, maybe 6% of getting some kind of a second cancer. So expressed in those terms, it's a doubling, but it's at that lower end of the scale, with Revlimid, 4, 5, 6%, depending on the length of the follow-up. But it's definitely something to consider, and these days, we can look at, well, maybe we should use Velcade or Ixazomib, which is the new oral proteasome inhibitor, as a maintenance versus Revlimid, and so it's something to think about and discuss. So I would say that with the awareness, my own experience is that there's the opportunity to diagnose early. And my own experience is that I use PET-CT scanning as part of my monitoring, and it has not impacted directly the survival for many of my patients, because I've been able to diagnose early and actually have curative treatment for a number of my patients. So I don't know how that situation was for your husband, but definitely a concern, and so I'm sorry that was a problem.
Okay, thank you.
And your next question comes from the line of Phyllis.
Dr. Durie?
Yes.
Thank you very much for the outstanding work that you're doing, along with many others around the world. I am very fortunate to be in a ELO trial, ELO Revlimid Dex, to which I'm responding beautifully.
Great. Okay.
At the same time, I am pushing hard towards the cure, and I think we're going to get there. What are your thoughts and views on this CRISPR-Cas9? And I believe tests on myeloma patients are beginning this month.
In Philadelphia.
Yes.
Yes. So I think that, time will tell. I mean, I think that this is a technology. Actually, within the cancer moonshot, myeloma was one of the 3 cancers picked for this trial program, and so I think that it's exciting technology, and I think that the problem, don't misunderstand me, but I mean the idea is that we need to have a selective immunity against the myeloma that does not damage the normal immune system, and so it's been difficult to have the correct target, so that CD19 for the CAR T cells, which the Philadelphia group used, it also damaged the normal B cells, so that there was basically an immune deficiency. So I think that a lot of interest in this technology, and I think it could lead to something very important.
My experience has been my natural immune system has been already damaged. I think by the treatment, perhaps by the disease process, but it's definitely been damaged in the IgA, IgG. Those numbers are very low.
Exactly.
So I may not be completely understanding what you're saying about that type of situation in the face of CRISPR-Cas9.
Right. Well, I think that the problem is that the therapy can get rid of the myeloma, but then it doesn't recoup the normal immune system.
Exactly.
Yeah, that's the problem. And so I think that, giving back NK cells, some of these other technologies offer different advantages, using these checkpoint inhibitors, which basically recruit your immune cells that you have and stop them from being blocked. I mean, I think that the discussions that occurred in Copenhagen where people were still waiting to see which of these approaches would turn out to be the most promising,
And those people who have myeloma who are going into the CRISPR-Cas9 study, is it a correct assumption that they all are immune compromised?
Oh, yes, I would think so. Yes.
Yeah.
So, yeah, I mean, that's the nature of myeloma,
Yes.
Yeah. So anyway, it'll be just exciting to see how that moves forward. As you know, it was just announced the other day that that's going to be happening.
Yes, it happened to be on the cover article on the July 4th issue of Time magazine, for those who haven't read about it.
Exactly, yes.
So it's current.
It was mentioned as part of that Time magazine article, yes. It was one of the first things that it mentioned, that was myeloma was going to be part of the trial, yeah.
Well, we certainly have many questions still to answer, don't we?
Yes. Thank you, yes.
Thank you for your work.
And your next question comes from the line of Diego.
Hello, Dr. Durie.
Yes.
Hi, this is actually Mariella, Diego's wife. My husband was diagnosed in April with advanced multiple myeloma. He was on VRD, but the doctor started the Revlimid, I'm going to say probably a week and a half later. I mean, the three weren't started together. They didn't begin together.
Okay, started with the Velcade and then they added in the Revlimid, yeah.
Right. Now, when the results came back, his IgG, instead of going down, it went up. So the doctor was, she was really terrified, and she sent him over to, Diego is now seeing Dr. Jagannath's team at Mount Sinai.
Okay.
After the first, he immediately put Diego on KRD. And after the first cycle, his number went down to half with just one
fantastic.
cycle. Yeah, so the doctor was really happy about that. My question is, the doctor says he's going to give him 4 cycles of KRD.
Yes.
What kind of food should Diego be eating? What type of exercise? What do you recommend for him to do? He says that he thinks that with just one more treatment, after this treatment is completed, which is this weekend, that Dr. Jagannath is thinking that his numbers are going to go to normal.
Way low. Yeah. He's going to do really well. I mean, it sounds like he's responding with the KRD, which has a very high response rate across the board, even with high-risk patients. And so he will be doing well, certainly within the 4 cycles. And so as far as the myeloma, it should come rapidly under control. And then you'll be dealing mostly just with the side effects. And hopefully, if he's tolerating well, he'll be able to get back to a lot of normal things rather quickly. So obviously, during this first phase, it's very stressful and, a lot of monitoring, and so you don't want to be pushing too hard during this early induction period. I think that as far as food, just stick with, normal food, not anything exotic. Try to stick with healthy food, normal vegetables and, fish, and stay away from a lot of processed foods. I've actually written a lot about different food things, healthy eating, and so we could, if you call the hotline, I think we could probably give you some tips on eating, okay?
Great, Doctor. Do you recommend juicing?
No, I actually don't, specifically juicing. It's better just to eat the fruit, okay? That's just a small point, but I think that's the thing.
And your next question comes from the line of Joanna.
Yeah, hi, Dr. Durie.
Hello.
My husband is taking daratumumab,
yes.
but he can't tolerate Revlimid or Velcade, so he's taking it with Pomalyst.
Oh, yes.
Have studies been done, or how effective is it with Pomalyst? Because I always hear daratumumab, Revlimid, Velcade.
Right. Well, funny you should mention that, but actually there's a very nice study with pomalidomide as well. It was actually presented, the main presentation on that was at ASH. But yes, daratumumab works very nicely with pomalidomide, and actually this could become a priority combination because actually many patients will have received Revlimid with their initial therapy, and so moving forward, they might need basically two relapse drugs together, so that daratumumab and pomalidomide would be ideal in a relapse setting in patients who've had prior therapy. So the results show that it's well tolerated and have an excellent response rate. So I would be expecting good results with that, actually. So this is great.
Oh, that's wonderful news.
Yes. So hang in there, and similar to what I was just describing, I would expect that maybe quite quickly, within a few cycles, you should see some good results with that.
Thank you.
Yes.
Thank you very much.
Oh. And we have time possibly for maybe one more question, I think, because we don't want to exceed our timing here. So as we're approaching the hour, so do we have someone else here?
Yes, and you have a question from the line of Richard.
Yes, hi. Just a quick question on the Pollux trial. How many patients before being entered onto the trial had been exposed to RevDex? And of the patients who got put on the Dara-RevDex combination, what percentage had to drop off because of toxicity?
The drop-off rate was very low. The requirement was that patients could be exposed but could not be resistant to the RevDex, because obviously the randomization, some patients got RevDex. So that patients, I don't have that exact number, but obviously a number of patients had RevDex, but they could not have been resistant to RevDex or intolerant to RevDex.
And then differences in toxicity between the two arms?
There obviously, with the daratumumab, the main thing is allergic reactions, which mostly come with the first dose, but those were manageable, and some increase in effects on blood count, especially platelets, but really quite manageable combination toxicities, I would say.
Good to know.
Yes.
Yeah, I gather there's some problems with
all right. Thank you for that. We can get you, if you would like to know more detail on that, please call the hotline and we can get you the exact percentages on some of those things, okay? I think we should stop now, so I'll turn it back over to Susie, who will give our closing comments.
Thank you, Brian. Joanna, if you're still listening, I just wanted to note that you can find on our website the recording from our Living Well teleconferences, and there is information on that about nutrition.
Okay, yes.
So anyway, thank you, Brian. That was outstanding and very informative as always. I'm sure everyone on the call tonight appreciated the information, and most likely a lot of tonight's listeners will still have some questions. So for those of you who do, I suggest that you call our info line, and they'll be able to help you. The toll-free number is 800-452-2787. 2873. And the info line is open from 9 a.m. till 4 p.m. Pacific Standard Time. And they're a wonderful team. They have so much information. Another really fantastic way to stay abreast of all the new data and how it impacts your treatment is to attend one of our patient seminars. And our next one will be right here in Los Angeles on August 19th and 20th. And then, and if you can't make the Los Angeles one, my colleague, Kelly Cox, holds regional community workshops across the U.S., and I suggest you go to your website and see if there's one near you. So once again, I want to thank our sponsors, Amgen, Bristol Myers Squibb, Celgene, Janssen, and Takeda Oncology. I also want to thank our wonderful support group team here at the IMF, Robin, Kelly, Nancy, Sue, and Ann, who work with the support groups across the country, helping them in so many positive ways. If you don't belong to a support group and would like to join one, call our info line, and they'll be able to not only answer your questions about medical stuff, but also tell you where there's a support group near you. Excuse me. I get choked up at the end of these. So that's it. Have a wonderful evening, and I hope to see you all soon. Thank you.
Thank you so much, everyone, for participating in this call.